Well, my name is Bob Spilla. I am the clinical educator for respiratory care, and today we're going to talk a little bit about the usage of CPAP and the various flavors and administration to your patients. So I hope you enjoy the presentation.
So this afternoon we're going to talk a little bit about CPAP and the role of CPAP. We have a number of different flavors here at Edward Hospital, and what we're going to focus on this afternoon is we're going to go ahead and look at the way CPAP is used in the field. We call it hyperinflation therapy because we have a couple different ways to go ahead and treat the patient with a pressure therapy. So let's take a look. CPAP is defined as continuous positive airway pressure. You may hear the terms PEEP, positive and expiratory pressure, used interchangeably with that. We tend to use CPAP as the name for our that we use with our spontaneously breathing patients. PEEP we'll usually use with our patients who are intubated and were mechanically ventilated, but both therapies are the same. They both involve end expiratory pressure, and we'll show how we're able to treat the alveoli in certain disease states like that. We'll take a look at some of the features of CPAP as it's used in the field. We're going to use CPAP when oxygenation is a concern as opposed to ventilation. Sometimes we'll be a little more concerned about ventilation when we're in the hospital, but oxygenation is our patient's primary concern. With CPAP devices, we're going to set an expiratory pressure only, so it's a relatively simple setting and straightforward. Obviously, the patient has to provide their own rates. There's no ventilation involved, and we'll talk about the criteria for when patients actually are candidates for non-invasive. And the great thing about CPAP is it can be a simple or a complex setup. The RTs at Edward Hospital, we've chosen to use our complex machinery, and it's just the way we set it up in the particular mode that we're choosing CPAP or we're using for ventilation. The Whisper Flow is a great system, and it's relatively simple setup with flow and resistor valves along with the patient circuit, and works pretty well. Now, not all our patients can qualify for non-invasive therapy. You have to be able to meet a number of criteria. We obviously want to have some reversible disease, so we're just kind of buying time in the meantime for the next therapy to come along. Patients got to be able to protect their own airway as well. So patients who might have impaired neurostatus, upper airway obstructions, secretion clearance, or nausea and vomiting, obviously we have some airway concerns on that. Those would potentially be good candidates. Patients got to fit. Patients come in all shapes and sizes, and we've got to be able to fit the patient to the therapy. Oftentimes that can be a challenge depending on what kind of equipment you have. I prefer my patient to be cooperative in order to be effective. So when I place my patient on the non-invasive therapy, I want to go ahead and be able to ask them as they're breathing better or subjectively how are they feeling. I want to get a little feedback. It's not completely necessary, but it's a nice thing to have to go ahead and ask the patient how they're feeling after I begin the therapy. And something that especially affects you guys, no facial trauma or hemoptysis. Obviously, we've got to have a decently fitting mask for your patient, so we want to make sure you've got a good fit. Just a tiny bit on physiology. Basic lung unit, as you probably already know, is the alveoli. Average adult has about 8 to 12 million alveoli. And nice thing about that, it's got a nice match. Each alveoli has a nice match to the pulmonary capillaries. So as oxygen enters the lung, it goes and diffuses across the membrane and enters the bloodstream through the pulmonary capillaries. When there's no longer a good match, as we'll see in a second, that's when the problems come in, and that's where the role of CPAP will really help us out. So for example, in CHF, obviously a failing pump can cause the pressure to rise in the pulmonary veins, but we can't really treat a pump in the field very well, so we're going to kind of treat it as a overloaded fluid situation. So a rise in the pressure can cause fluid migration into the alveoli. We're going to have a little bit of alveoli collapse, and poor gas exchange will result from that. We'll see we'll be able to treat that. Little slide on typical CHF patient. Certainly pulmonary edema, have some excess fluid in your lungs, as well as the swelling in the ankles, and just tired and shortness of breath, and I think you're beginning to see the clinical picture about that. Little slide here shows you how, as the alveoli reinflate, there's just a better match. Alveoli on the left is kind of collapsed, maybe a little fluid filled, and as we apply our CPAP therapy and our pressure, it gets the alveoli to reinflate and get a better match with those capillaries. Remember that CPAP is not a natural way to breathe. Positive pressure is just a natural occurring thing in the chest, so it will increase your intrathoracic pressure and decrease your venous return. It may drop your blood pressure, and it may be a real problem for patients who are already sick enough to be hypotensive. So you may need to treat that hypotension first, and then consider CPAP therapy, which may cause another issue in blood pressure. So just a couple things to watch out for. Remember, we're just buying time with CPAP, so we're going to use other therapies to add to that. For example, nitrates to reduce our pressure, and we're going to try and remove that fluid after we get back into the circulatory system, and make our CPAP level in conjunction with your SOPs. So let's talk about a little about device placement. We're going to take the CPAP and explain the procedure, kind of describe the equipment so the patient's not so frightened. A little slide in there that says sometimes you have to lead by example. Apply your monitors as needed, and sometimes we a little focus on that. Quite a few monitors in this patient, but obviously we have some standard things that we want to go ahead and do. One thing about your monitors is that when you apply a pulse oximeter, and I know it's probably using the model that has a finger clip to it, but if you're using a wraparound, you want to make sure those diodes meet each other, they can see each other, because one side is a transmitter, the other side is a receiver for the amount of light. Want to make sure you apply sufficient flow and place on the patient. What you'll notice on the whisper flow CPAP is that the lower your FiO2 is, the louder it is, because you're in training room air from the back of the device. As your FiO2, your fraction of inspired oxygen, goes up, it's going to be a little quieter, but it might be a little bit more of a challenge to go ahead and meet the patient's needs with 100% oxygen. May have to modify a little bit and place a reservoir on the tail of the whisper flow. Want to make sure that you know your proper setup of equipment. Make your therapeutic response. You're going to make your adjustments as you need to. And if you need to modify your equipment, you can certainly do that. It's just important to know the usage of your equipment. For example, some manufacturers recommend, if you're going to go ahead and increase your CPAP from 10 to 15, from 10 to 5, just go ahead and use the 15 valve as opposed to stacking them. And then also make sure that you know the limits of your protocol as how high you can go as far as treating the patient. So they want to monitor vitals. Obviously, some patients require more coaching than others, some encouragement. Patients may feel as though they're being smothered at some point in time with the mask, so want to go ahead and give the therapy a chance to work. And don't be afraid to move on to more aggressive measures if you need to. You should see a response in about 5 or 10 minutes, asking the patient how they're feeling, get a little subjective feeling from them as far as the therapy is concerned. So if I don't see a response in 5 to 10 minutes, I may need to move to something else, or maybe to a little more aggressive therapy with that. Also want to let the hospital know about your CPAP patient in the ER. As the RT is on duty, he does have a stock of equipment at any point in time. However, if it's a busy day in the emergency room, may need to get some additional equipment, so you want to make sure that you have a smooth transition for your patient. So we're going to leave the CPAP until the hospital therapy is ready, and we can always make the transition then. So in summary, it's obviously a safe and effective therapy. We want to make sure you use it on the right patient population. Certainly want to consider your diagnosis and contraindications and your special warnings, such as if your patient's already hypotensive, to go ahead and place a patient on positive pressure. Obviously, we're just buying time and we're treating. So you certainly want to be familiar with all your protocols, your limits, your SOPs, and definitely the operation of your equipment. Want to monitor the patient closely, especially after initiation of the therapy or any changes, and especially in terms of blood pressure. And don't be afraid to move on to more aggressive therapy. If the patient doesn't respond, you may have a bigger problem on your hands.